Hi, good afternoon to everyone who has joined us for our latest Medstrom webinar. I'm Debbie, Medstrom's Clinical Director, and I'm accompanied by Helen, who is our Sales Director. We extend a really warm welcome to everyone who's joined us today. We really thank you for your time.
Today's webinar will begin with Alison Schofield. Alison has over 24 years experience working across all settings, including acute, community and primary. Alison is currently an honorary TVN at York Teaching Hospitals NHS Trust and clinical manager for Mole Digital. Alison's session focuses on the widespread and far-reaching impact that the COVID pandemic has had on patients, tissue viability service delivery and wound care, noting that some changes have been positive.
At about 2:20, we'll hand over to Emily Haesler. Emily is a professor with the Wound Management and Healing Unit at Curtin University and an associate professor with the Australian Centre for Evidence-Based Aged Care at La Trobe University. Emily has extensive experience as a methodologist in Australia and internationally, having led the development of 8 Australian National Health and Medical Research Council endorsed clinical guidelines and 4 international interdisciplinary clinical practice guidelines in wound care. She is the methodologist and editor-in-chief of the International Pressure Ulcer Guideline 2014 and 2019 editions and the Pan-Pacific Injury Guideline 2012. We're really fortunate to have Emily deliver her session focusing on the process used to engage patients and family carers in the guideline development process. Due to time differences, Emily can't join us live, but will engage with questions you pose to her after this event.
Around 2:35, the last presentation will be from Alison Parnham. Alison is a clinical nurse specialist tissue viability with 26 years experience and having worked across primary, secondary and tertiary care. Alison is a practitioner health lecturer for the Faculty of Medicine and Health Sciences in Nottingham University Hospitals. Alison's session will focus on the shared experiences of patients living with pressure ulcers. So let's start with the first presentation and welcome Alison Schofield.
Thank you, Helen and Debbie. Thank you so much to Medstrom for inviting me to speak today. Welcome to everybody who's joined us as well. So let's get on to our presentation. There we go. So this is around an article that I wrote for the Nursing Times about the impact of the COVID-19 pandemic on chronic wound care and its practices. So what do we know and where are we? You know, we keep hearing about the burden of wound care, which actually was completed on data from 2017 to 2018. So it's actually before the pandemic. And even then, we'd had a 71% increase in wounds in a 5-year period. And the spend was 8.3 billion. I think the interesting thing for me from this data also is the increase in the number of visits in community and primary care. You know, 54.4 million district nurse visits, and also healthcare assistants. So that shows that, you know, that change in practice within the workforce. And, you know, there's lots of questions and debate around what do we do about that, and you know, where do we provide education to support them. We've got figures there on the ageing population from the Office of National Statistics. That's telling us by 2028 the increase in the over 75s, you know, which is also then going to have a big impact on chronic, you know, comorbidities, which then will have a knock-on effect with wounds also. So the coronavirus pandemic highlighted that there was a low priority given to chronic wounds, and we'll look at that in a little bit more detail. But we know that suboptimal care causes unnecessary suffering. It means more patients are admitted to hospital, there's more patient deaths, and then that spend to the NHS, that 8.3 billion, you know, is just going to rise through the roof. So I'm a tissue viability nurse myself, and what is the role of that, you know, the specialist role in pressure ulcer prevention and management? Well, wound care is mostly nurse-led, we know that, and 2/3 of it is delivered in the community-based areas. So, you know, tissue viability requires specialist skills that the, you know, services and team provide. The role isn't standardised and it is poorly defined. And specialist resource and support isn't always accessed, it's not resourced very well. And we know from that burden of wound study that there was a 2% decrease in tissue viability access visits. So the TVN role historically has always been around advice and support. I know from speaking to tissue viability nurses and in my honorary role in the area of York that it has become much more hands-on and clinical, not just an advisory and support service. But education and training are really at the heart of what we do, and that's educating the rest of the health workforce, but also within social care too. So it's vital to focus on, prevention within wound care, and especially around pressure ulcers. We are not addressing service, so education for me, is the main part of what I do these days. But also the role of the specialist nurse is to advise our trusts and CCGs on things like the equipment selection, because everything we do is based in evidence, is evidence-based care. It has to be. And whether we are prescribing a dressing or, a mattress, a cushion, a heel offloader, these are prescribable objects. So we need to have that quality from our suppliers. We need their support as well in education. And we need to make sure that we've, our goals and aims made with our patients, families and carers are towards comfort, dignity and safety. So it needs to be at the, really at the heart of our care planning. So we know that, this has been impacted because of the pandemic. So what were those impacts? Well, the first wave with the pandemic, the plug was pulled on a lot of prevention work. The plug was pulled on education that was being delivered in our trusts. And some patients struggled to just get access to wound care, and some services struggled to provide even an essential, wound care service. So there were reports that patients were unable to access services. We know ourselves, trying to get into a GP appointment was very, very difficult. And, there were lots of services that were being redeployed, especially our specialist teams and tissue viability. Patients were being, kind of left without essential equipments of dressings and equipment at times, or there were long delays in this. I know from doing an audit myself in my last trust in North Lincolnshire, and the audit I did was this year, but was looking at the journey through the pandemic. And this was patients with leg ulcers, but the outcome will be the same across the board. And patients were, they were getting non-face-to-face visits. They were being prescribed antibiotics after antibiotics, given dressings, and by the time the specialist clinics could reopen and patients got seen, we had some quite severe wounds there. And anecdotally, we know that is across other wound types as well. So, experts in the field have been saying, chronic wounds have just really dropped off the priority list. It's never been up there as it should, as other chronic diseases are anyway, but, it did worsen through the pandemic. And, those other associated risks with COVID, we had a big cohort of people who were in a vulnerable groups who were being, who were impacted by COVID, being admitted to hospital, patients in ICU, people were being discharged back into nursing and residential homes to be cared for there to free up hospital beds and things. So, and even, in social care as well, we keep hearing about it in the media, the impacts to staff in there. So there was less focus on those earlier signs of risk assessment, putting those preventative interventions into place. And I know from leading pressure ulcer prevention teams in 2 different trusts, the focus we put towards education into care homes had a big impact, but then they were being redeployed into other areas to work in the past 18 months. The education stopped, the staffing issues, and we did see an increase in pressure ulcer reporting. We've also seen new skin manifestations through COVID as well. So that's something we need to be looking at and learning from. Increased dependency of those ill patients, like I said, and proning was a thing that was happening a lot in those, high dependency units, and a desaturation of oxygen. And so we were seeing different things like, deep tissue injuries on a different scale and new areas than what we'd seen before. And of course, the device-related pressure ulcers, we were using a lot more tubing, masks, and all these different things. So we were seeing and reporting on a lot more device pressure ulcers. So examples of the skin changes that we have seen, we've got the COVID toe. I don't know if anybody's heard of that. That was a new thing that seemed to spring up. And like I said, deep tissue injuries, especially around, the kind of that buttock area, things that you would often see and relate to in end of life we're seeing with COVID patients. There's the oxygen tubing, different masks that we had, and also moisture associated skin damage. We did an audit in North Lincolnshire and we found we'd got an increase because as part of NHSI guidance now that we are supposed to be reporting moisture-associated skin damage. So the incontinence-associated damage, like on the photograph here, we were seeing a lot of, and we were, attributing that again to, that the issues we had within, just social care support and people, just trying to look after themselves, look after their families at home and in lockdown. That's what we were advised to do, is to stay indoors and to stay away from people. We've got winter pressures coming up now. COVID certainly hasn't gone away. It hasn't gone anywhere, has it? And so we always get additional things within winter. So are we going to see a rise, increase further again with our pressure ulcer development? We need to, be carefully monitoring and watching the outcomes. We've learned from the past 18 months. So, let's be ready, and we need to be focusing on preventative care. So what were the impacts to the healthcare professionals as well? Well, many, and those of you in the audience who are working in the profession will relate to this. There were staff shortages and still are in all service areas. Many were redeployed. Some services, clinics were temporarily closed. There was the education was stopped, so people not getting education on pressure ulcer prevention, and then that in turn reduces competence in the workforce. That increase in reporting we've certainly seen, and then there were PPE and skin issues for the staff themselves, on the around the ears and the nose, and people having to wear for hours and hours on end, and so they were reportable pressure ulcer incidents in themselves. Increased stress and anxiety, stress and compassion fatigue, even in normal times, is a challenge to prioritise one's own emotions, psychologically and physical well-being. So that cost of caring, that prolonged intense contact with suffering patients, it can be absolutely overwhelming, and it really tests resilience. And it can cause traumatic stress, burnout, you get an exhausted workforce, and then people leave the profession. So that recruitment and retention, sadly, is kind of falls by the wayside. The impacts to patients, carers and families, obviously we have all seen and witnessed this, and patients were often discharged home earlier from their hospital because they needed to free up hospital space because the hospitals were just creaking at the knees. So patients, I know in the community we saw patients coming into in almost turning care homes into hospital wards, very sick, very ill, very frail patients, and sometimes in a palliative capacity as well. So it increased all the wound types. We kind of, we expected this. And those anecdotal reports we keep hearing more and more of really severe chronic pressure ulcers and other wounds. Some of the chronic pressure ulcers that, you know, I mean, we know we still see category 4 pressure ulcers, but some, you know, reports are saying, gosh, we haven't seen things like this for the past sort of 10, 20 years. Also, there's a fear of accessing support from healthcare professionals. Lockdown, you know, people are afraid, were afraid to go out to access the services or even let people in through the door. You know, we've got vulnerable groups of patients in our care, you know, and they had to protect themselves, and we wanted to protect them. There was increased physical impacts on chronic wounds, you know, that pain, malodor, exudate, reduced mobility, all those things that, you know, it can affect a person's life. And the psychological impacts living with a chronic wound, you can get anxiety, depression, social isolation, and that fear and just helplessness. So quality of life, you know, we have to measure because it does impact and affects all aspects of a person's well-being. And also lack of education towards patients and carers. You know, we need to, you know, ensure we really firm this up, and that receiving of and delivering of suboptimal treatment interventions with the equipment and dressings, you know, had definitely had a knock-on impact. So sadly, these are the types of pressure ulcers, you know, the real big, horrible, chronic, you know, category 3 and 4 pressure ulcers, and the burden of wound care told us it can take between 9 and 50 months for pressure ulcers to heal. So positive elements to take forward, though, because there's always positive things to take from when we've had bad situations. So you can see their advancement on the patient self-care agenda, which is part of the NHS long-term plan of health coaching, involving families in the care pathway development, greater focus on digital solution, national wound care strategy, doing a lot of work around this, highlighting the need for specialist services in wound care more than ever, and collaborative working, all of us together across health and social care. So please take away some learning points and reflection from this, that caring for people with chronic wounds needs to be prioritised. The barriers to supported self-care and telemedicine have been lifted, but we still need to do a lot of work on this, and it won't suit all patients. Self-care certainly doesn't mean support and good, you know, that support and good shared care systems are no longer needed. You know, online teaching that we're doing so much more of, you know, is a different skill. So we need to make sure staff have appropriate training for this. And we're looking also on that holistic assessment of teaching patients around diet management, exercise, smoking cessation, and all those things which impact on wounds. So how can we make a difference? Well, I just want to say that everything we do must be measured, because data speaks volumes. So, you know, gather all your data for your healing wounds, on non-healing wounds, infection rates, measure your outcomes effectively, put smart interventions, smart principles into place, and your quality of life tools. And then you can take these to your senior leaders, and we can then together tackle this burden of wound care. Thank you very much.
Alison, on behalf of everyone listening, I want to thank you for setting the scene of wound care with the overview of the burden of wounds, showing that wound care is as much a priority as other health conditions in the UK, and then helping us to see how the pandemic has affected patients, staff, and carers. So I'm going to allow us to play Emily's session, which, just as a reminder, is pre-recorded because she's in a different time zone to us. So we'll welcome Emily and her presentation next.
So thank you for that lovely introduction. My name's Emily Haesler. I'm a Professor of Wound Research at Curtin University and a Guideline Methodologist. And I'm just going to share my slides with you. Hopefully these are coming up for you now. So today I'm going to talk to you about the International Pressure Ulcer Guideline. This is an evidence-based clinical guideline that's used in over 40 countries around the world. And in this presentation, I'm going to talk about the process we use to engage patients and their family carers in the guideline development process, and the findings from a large patient survey that we undertook. So patient and public involvement is a requirement for high quality clinical guidelines, and this has been recognised by governments and other bodies that endorse clinical guidelines and support clinical guideline development. For example, the National Institute for Health and Care Excellence in the UK has started to involve patients in their own guideline development, and they recognise that patient engagement is important in attaining high quality healthcare systems. And so we have this quote on the screen. This is from the Health and Quality Safety Commission of New Zealand. This is the next frontier of patient and family engagement, using the experience, expertise and insight of patients to improve care. And this statement was published in 2015, which was around about the time that we were planning the methodology for the 3rd edition of the International Pressure Ulcer Guideline. And it reflects that guideline development group's passion for reflecting the perspective of patients in our guideline development. The purpose of including patients and family carers in guideline development is to ensure that clinical guidelines are patient-centred and that makes them gain more trust. So involving patients in the guideline development encourages and respects their engagement in health policy development, and it empowers patients to make informed health choices. But most importantly, it recognises that patients are experts in their own needs. So to embrace the move towards patient involvement in guidelines, which was relatively unique at the time that we engaged in this process, we focused on care priorities and care goals of patients, information needs and patient problems. The first area of care goals influences the development of individualised pressure ulcer prevention plans and meeting patients' needs. So from a guideline perspective, we wanted to know what's important to patients so that we could make sure that the clinical questions answered in the guideline were relevant. Information needs influences the sorts of resources that patients might need to support a clinical guideline. And the third area, patients' biggest problems, helps us to identify areas that patients and family carers need more support in. So the biggest barrier we faced in this project was that the international guideline is used in over 40 countries. And we had a goal of engaging family carers and patients across such a huge region with very limited resources. So we chose a really practical option of delivering an opt-in anonymous online survey with mixed methods questions, collecting qualitative and quantitative data. So this survey was designed by team members who had experience in patient engagement, and it used simple language, it used a point and click interface. We had a small number of multiple choice questions to reduce respondents' survey fatigue, but we also included open response questions because we wanted to explore the biggest problems faced by patients and their family carers. We wanted patients to really be able to tell us their story. So the survey was reviewed for face validity by the Guideline Governance Group, and then it was translated into 9 different languages. And we disseminated this survey through professional conferences, through the Guideline Development Group members delivering it directly to patients. We used social media and we used community organisations in some countries. The project had ethics approval from the Australian National University, and the survey was available online for about 6 months in the middle of 2018. And then for our data analysis, we did descriptive statistics and a thematic analysis of the open-ended question. So what did we find? Well, we had a bigger response than we really hoped for. We had over 1,200 respondents, and about 380 of those identified as patients. About 86% of these respondents were from Asia, mainly China, and 3.5% were from Europe. So there's probably a few reasons that we had more respondents from Asia. First, China is over 3 times the population of Europe, so we would expect to have more Asian respondents. But the survey also happened to coincide with a lot of Asian conferences, so it got a lot of promotion in that region. And we also found that health professionals in China were able to distribute the patient survey link very easily because they have a high digital connectivity with their patients, and that wasn't the case in all countries. So when we look at the responses of individuals, and this is people who are identified as having had a pressure ulcer or being told that they were at risk, we see that about 37% of patients were aged over 60 years of age. And we know that this isn't really reflective of the risk groups, because we know most people who are at risk of a pressure ulcer are much older. And also we had younger family caregivers as well. And we think that this is probably a reflection that it was an online survey and these cohorts probably use the internet a bit more. So this graph shows the care goals of patients. Stopping any pressure ulcer was the most common, with 69% of respondents saying that that was their major priority. But 45% of patients also had a goal specifically to reduce large pressure ulcers. And we see that family caregivers had essentially the same patterns of response for goals related to pressure ulcer prevention. About 47% of patients selected reduction in the size of a pressure ulcer as their primary pressure ulcer healing goal. So reduction in pressure ulcer size was actually selected more often than completely healing a pressure ulcer. And I think this is really important information for health professionals who can become really disheartened if a pressure ulcer doesn't heal or it takes a really long time to heal. Just to know that for the patient, reduction in the size of that pressure ulcer might have already met their main goal and made a big difference to their quality of life. And once again, patients family caregivers responded very similarly. Here we have responses to pressure ulcer symptoms, and we can see that 46% of patients had managing pain as one of their main care goals. And here only 36% of family caregivers had similar goal, and this was one of the only statistically significant findings in our survey. So I think this is really important to be aware that when working with family carers advocating for a patient, just that pain management isn't overlooked as a goal. With respect to information needs, all of the dark and light blue in this chart indicates strong agreement or agreement that various clinical topics are important for patients to receive information about. So basically, patients and family carers agree that they need information about all the topics that were eventually covered in the international guideline. Here we can see the top 5 information needs that were identified by patients. And this is quite interesting because 2 of these top 5 areas, health professional education and facility-based pressure ulcer prevention plans, are actually quality improvement initiatives of an organisation or a wound service. So these are possibly areas that we give patients less information about. And it reminds us that an effective facility-based pressure ulcer prevention plan needs to engage patients and their family carers. So caregiver responses were fairly similar. They had the same priorities for organisational level quality improvement initiatives, which are the ones in red. But it's important to look at these in the context of the very first slide I showed about information needs. And I think the take-home message is that your patients and their family carers are likely to be highly receptive to information about any pressure ulcer topics. So we asked the survey respondents an open-ended question about their biggest problems related to pressure ulcers, and over 500 respondents provided short answers. These were translated, and then we used a thematic approach to identify the key themes and categories and subcategories. So the data contained 5 major themes, and these were health, the wound, care, information, and quality of life. So first, for many patients and family caregivers, their overall health and the resulting pressure ulcer risk factors were their biggest problems. So they recognised that being limitations in their moving and repositioning was a problem, and that this led to an increased risk that they would develop a pressure ulcer. So these respondents basically looked at the primary cause of their pressure ulcer, their reduced mobility, and recognised that it was their biggest problem. Other health problems such as frailty and cardiovascular disease also increased the risk of getting a pressure ulcer, and also it impacted the ability of patients to implement preventive interventions such as repositioning. The wound, the pressure ulcer, was central for most of respondents. Patients and family caregivers referred to difficulties in getting a chronic ulcer to heal. They referred to dealing with many remissions and recurrences. They talked about complications such as wound odour, exudate and infection as being a major concern. And a theme of concern relating to caring for the pressure injury, knowing the way to clean and dress the wound was also evident for many patients and their family carers. So the primary theme around care referred to accessing care services, and this included accessing both informal and formal caregivers and also equipment such as mattresses and beds. And these responses are from people living in the community who are at risk and have limited access to equipment that they need to help them stay pressure ulcer free. So this reminds us about facilitating our patients to access the equipment they need, particularly beds and mattresses and seating supports. And financial costs did come up in this theme, but that was primarily related to the cost of wound dressings, which is different in many different countries. So information theme identified the concerns that patients and family carers have regarding the knowledge, attitudes and skills of their health professionals. And this reflects what we saw in the quantitative data, that patients are interested in quality improvement initiatives. But patients also identified their own lack of knowledge and self-care abilities and noted that this was a big problem for them. And we also saw that in the quantitative results where they indicated that they needed information on many topics. And the final category that we found in the qualitative data was quality of life, which was a significant theme for both patients and family carers. So patients referred to pressure ulcer symptoms that impacted their quality of life, particularly pain, and this converges with the quantitative survey findings that almost half of patients had managing pain as a primary care goal. But for other responses in this category referred to the psychological burden of pressure ulcers, fear, and family carers' burden of caring. So how do we use the survey information? So in the clinical guideline, all the evidence-based recommendations have a strength of recommendation, and every one of these strengths of recommendations indicates how likely implementing the recommendation is to achieve more good than harm for a patient. So using a grade approach, we assigned strengths of recommendations, and the development team considers in that not only the volume and the quality of the research, but also the acceptability of an intervention for patients, whether it's feasible for patients and whether it's a priority for patients. And this all feeds into the strength that any given recommendation in the guideline receives. So there was some specific recommendations in the guideline that the survey results supported. And the first of these is to set treatment goals that are consistent with the values and goals of patients. And this includes reconsidering those goals when the pressure ulcer isn't getting smaller. And also important to remember to incorporate family carers in goal establishment, because as we saw, family carers have very similar goals to patients for the most part. The second good practice statement there that's in the guideline is about assessing health-related quality of life and knowledge needs. And we know that's very important to know what deficits are before we can help patients to learn what they need to know. And the third there is an evidence-based recommendation about providing pressure ulcer information. And the guideline includes strategies on how you might do that, including routinely discussing pressure ulcer care with patients, using evidence-based education resources, and using a range of different education delivery models. So this study has just been accepted for publication in the Journal of Tissue Viability, so look out for that in the next couple of weeks. And you can find more information about the International Pressure Ulcer Guideline at the Guideline website. And there's also an app available that there's a QR code for on the screen. And next month we're doing an evaluation of that app. So if you download the app, you'll be able to respond to that evaluation survey. So thank you very much. I hope you enjoy the rest of the presentations today.
Thank you to Emily for preparing and delivering that great presentation. I hope you found Emily's session explaining the process used to engage patients and their family carers in the guideline development process insightful. As you know, due to the time difference, Emily cannot join us live, but will answer questions that we put forward to her after this webinar. As Debbie said, should you have any questions for our other speakers, please submit them and they will be addressed at the end. Our final speaker is now going to provide an impactful session surrounding the human experience of living with a pressure ulcer. We now welcome Alison Parnham.
Hi everybody, thanks Helen, and thank you to Medstrom for inviting me to take part in this webinar. It's been great to listen to both Alison, Schofield and Emily, and interesting to hear about the huge impact that we've been living with the COVID pandemic. And interestingly, listening to Emily, if only I'd had access to her research when I was doing a literature review. And so, well, looking at my first slide, what I want to share with you is the impact of pressure ulcers on patients' quality of life. So we know, and certainly from some of the aspects that Emily talked about, we know that pressure ulcers have a huge impact. And I want to share that with you. It's important that we hear the patient's voice and that we seek to understand that true experience of patients living with pressure ulcers. So moving on to the next slide, it is about the patient's voice. It's about the patient's experience. And I chose two research papers that were phenomenological in their design and qualitative. So a bit like the process that Emily has talked about. They were smaller studies, they were older studies, as you can see, but although the studies were 12 years apart, the themes were very comparable. And you can see the list of evolving themes there, and that wasn't all of them, but I've chosen 6 key themes because what I also wanted to do was then interview patients. So I interviewed 3 patients using a semi-structured interview technique with open-ended questions to get them to really express their feelings. Slightly different age gaps between them, so one video is a bit older than the others, and what I've been able to do is compare the themes from the literature with what the patients actually told me in the interviews. So really quite emotive in how they come across and how they express their feelings. So the first theme was the perceived etiology of the pressure ulcer, and Emily touched on this as well. It's about the patient's level of understanding, and we have to identify that and sometimes just dig a little bit deeper, not presume that the patient actually knows how they even got the pressure ulcer. And we do talk a lot about risk factors to patients, but do they really understand? There's quite a lot of vagueness here. Before we move on to talk about Ron, there's a vagueness of, oh, I think I got it in the bathroom. So the comments on the left-hand side of these slides are from the research, and then obviously the comparison with the video on each slide. So I think I got it from sitting on the wheelchair for too long. None of those patients actually mentioned pressure. So every patient is different, and every patient will have that different experience and different level of understanding, and it's for us to really get to understand that experience. So the first video, you will meet Ron and Gwen.
Yes, I was getting out of my car between 2 cars, and my chair tipped one way because of the uneven tarmac, and I came out, but they couldn't get me back in the chair from that angle. I couldn't get back in the car from that angle, so they had to drag me. It made a slight graze. The nurses cleared the graze up, but at the bottom of the tailbone, it was like a sweat mark, and all of a sudden, you took over from there on.
Right.
I went to that picture which we've got. It was a big mess, and that was the start of it from the word go. I could see something was wrong. My wife standing there. It was just frightening.
And there was infection then at that point.
Yes.
That's when they was all saying, "We've let it get like this. It's your fault, like, you know."
I actually got pressure ulcers in 2 stages, really. I got some in my feet, which occurred approximately 4 years ago, and then due to a bone infection, I got one on my left buttock, which would have been about 1.5 to 2 years ago, I suppose. The ones in my feet occurred, we believe, through pressure, as in weight through my legs into my feet onto the pressure plates. But the one on my left cheek was caused through tracking out from the bone infection I had.
Went into hospital and was immediately on a life support machine for 3 months, and obviously during that period I wasn't able to be moved very much, and accordingly the pressure sore must have developed during that time.
Okay, so I think we can see from that the variation in the patient's level of understanding. So although David and Lanny seemed to understand more, there was still that element of vagueness of how much did they truly understand. So that was around the perceived etiology. And the next theme looked at the pain and discomfort. And it's not just the pain and discomfort, and I say that deliberately. It was the intensity and the duration of that pain and discomfort. It was words like, you know, constantly burning, no escape from the pain, and I thought that this was really hard hitting. You know, no escape from pain. That's devastating to have to live with that pain for something that you could argue could be prevented. And the impact of that on the other aspects that we'll talk about, the social aspects, the psychological aspects. So pain and discomfort has a huge impact on other aspects of quality of life. You know, immeasurable, unbelievable, constant. So let's now look at what the patients we interviewed said about that.
First of all, I'm constantly uncomfortable. I'm at times in great pain. Right now, I'm sitting here, but I'm very uncomfortable. I don't know if you can see it, but I'm sitting on a special cushion, which I have to use whatever I do, wherever I go, whether it be a car, people's homes, flying somewhere. I have to use it because if I don't, the condition worsens and the discomfort increases. So my life is really seriously affected by it.
So you can see the impact that has. It's the word constant, never ending, you know, continued pain. Just waiting for the next slide to come up. So moving on from that element of pain and discomfort and looking at how that then impacts on the other aspects of quality of life. There's a physical functioning, and this was a very common aspect that all patients, both in the literature and in the patients that I interviewed, it wasn't an inconvenience. It was a physical aspect of that changed their life. It changed how they were able to function physically. It changed how they felt about themselves psychologically. Spending a number of birthdays in hospital, and you'll hear Ron's experience. Not being able to sleep the way that they normally go to sleep. You know, the impact of that change in the physical functioning is enormous. So let's listen to Ron and the other
Why do you think
interviews.
you are? Why do you think we kind of the nurses say you must stay for a longer period of time in bed?
Look, because the pressure shot, so you can't sit off it. I've got to keep off it at the present moment. My wife's been really seriously ill. I've been married to her now for 50 years. I spent my golden wedding anniversary in the city hospital just lately, July. It was lovely, your golden wedding anniversary. But she's been really, really ill. And at 3 o'clock in the morning, she gets out of that bed. She can't even stand up some nights because she's got stars in front of her eyes. But she's still turning every 3 hours. Just get up. If you've got your wife laying in bed poorly and you can't get up to make her a cup of tea, or you can't get her a slice of toast or something just to help her, I mean, she's not been eating, but that drives you mad. That really cuts through you. You're helpless. And yet she's still got to go and look after me. Well, I'm perfectly fit, apart from an ulcer on my backside. And you think to yourself, this is not right.
I was in hospital a total of 9 months, and nobody in that period was able to help or rectify the thing. Certainly I had help from tissue viability, but there was no great improvement because I was lying down for such a long time. So the extensive effort to improve my situation could only start after I came out of hospital in around about July, August 2011. And pretty well. I think it's correct to say that Alison was seeing me maybe almost weekly, and to try and start the process of the wound being healed. But it got to a point where no further improvement was being experienced, and I was put on a vac machine for a very long time. I think 1.5 years. I had this machine on my shoulder, around my waist, to try and improve the condition of the wound. It got to a point probably about a year and a half ago where there wasn't any further improvement from the vac, so I was taken off the machine, and discussions were started as to whether or not surgery could be considered.
The ones on my feet, which is on left and right foot, became quite infected, and then eventually it went down to the bone, which took a long period of time to then rebuild itself, as in repair itself outwards. And the one on my cheek was a good about 6 inches deep, with a big sort of cavity at the end of it. And it was the cavity which took time to, well, I had to have an operation, which they drained and healed, and again spent a good 2-3 months basically laying on your front in the bed just to try and repair it. And now, even now, I still have to be very conscious of the fact of releasing any pressure. So I spend predominantly quite a fair bit of time resting, which again, as previously said, it hinders your ability to go out and about, really.
Yes, so the impact on the physical aspect of those patients' lives is huge. Having to endure bed rest for that length of time was a huge factor, and to think that patients live with those pressure ulcers for that length of time, with all of those different treatments and interventions, and the frustration that brings, it has a huge impact on their lives. I think I was going to say the biggest factor, but I think they all play such a big role in terms of the impact on patients' quality of life. There were different words and experiences used within the psychological well-being of those patients' lives, but very hard-hitting words of misery, depression, anger, irritation, you know, almost experiencing some of those grieving processes of what those patients and certainly Ron's wife were experiencing. Again, the anger and the irritation about the physical impact, you know, not being able to do what they want to do, fed up with the length of time those wounds take to heal. And there is some stoicism, and we'll see that when we look at the next video, some stoicism and acceptance on one side, but then an open and honest fear explained on the other side. So let's have a look at the next video.
Just one of those things.
I would say the pressure ulcer has been your jailer, really, because it's stopped him from doing everything that we would normally do.
It's had such
It's the thing that gets you more than anything else. The sun shining outside.
yeah.
I'm feeling fit. I can't get out. As my wife will tell you, people will say, "Why are you still in bed?" It's like, you don't want to get up. Or you're always happy. But they don't know. I'm not going to lay there crying because they're there. Me and Gwen will cry on his own. We can manage. But why are we staying in bed? Oh, what kind of life have you got?
You can be frustrated and sad, and we mustn't get bitter.
Do you feel better?
I do sometimes. Ron doesn't. He is really, really brave. But I want him to be better. I just worry when he gets ill that, is this the last time? Because he has been so very ill over the time that he's, had the pressure sore.
Yeah, so you can see the stoicism with Ron there, but the open honesty of Gwen, and the fear that she was experiencing of every time he was admitted to hospital with a wound infection, or in another case he was admitted with septicemia. That fear that the family experience, is this going to be the last time I'm going to see him? You know, and that's quite an incredible psychological impact. Again, going back to something that potentially can be prevented, and to think of the pressure ulcer as a jailer, you know, that's about imprisonment, that's about loss of independence, and it's a very emotive analogy, really, to think of a pressure ulcer as a jailer. So the social functioning was another theme that came throughout the research and with speaking to the patients. And again, it was about that isolation. It's about having to stay in your room, linked to the having to spend more time on the bed. But the other aspect of deliberately not participating because of the fear of the smell being obvious, or because of the pain that those patients were experiencing. So let's think about the social functioning, particularly with Ron and Gwen.
What have the last 2 Christmases been like for you?
22 people all around this bedroom. A few twigs painted silver in the corner there with baubles on. My grandchildren around me and quiz shows, and no, I've got a marvellous family.
We always make a lot of Christmas and birthdays.
Every Saturday they come down, every Saturday.
Before he was confined to bed for this last 2.5 years, as he said previously, we were never in. We were out every day. After I retired, that was it. You know, we'd get up anywhere, just to be going somewhere, seeing people. We went to theatre. We had, you know, pre-theatre dinners, treats, because we could. And, you know, aside from the paraplegia, if you want to go to London for the day, you have to book the train. That's just a little bit of irksomeness, really, that you have to book everywhere before you go anywhere, you know. But apart from that, we have done as we please. People think that he doesn't care that he's in the position he's in, but of course he does. He wants to be out and about again.
Oh, more, as you know, especially with sunshine, you don't feel ill. Get out in the garden, do a bit of pottering around, get in the car and go.
Imagine carrying a vacuum machine around with you on the side of your body, or carrying it over your shoulder. The noise, people always asking you why, what, how, and you know very well that it's the only possible opportunity to improve your health situation. So my life is pretty bad at that.
Yeah, so very hard hitting about the quality of life aspect for those patients, and you know the sort of the way that all of those themes impact on each other. So how the social functioning and the loss of independence, you know, impacts on that psychological well-being. So yeah, I was going to say something else, but it's gone. So I shall move on to the last theme. And really that theme takes us back to the very first theme about that limited or that vague etiology of the patient's level of understanding of etiology, of how the pressure ulcer developed. And this takes us back to their recognition, the patient's recognition that they need a better knowledge and understanding. And hindsight's a wonderful thing, and you'll see that with Dave when he's talking about it. You know, I wish I'd known how to prevent a pressure ulcer before getting one. Can we really say that we can achieve that in clinical practice today? You know, I know you need to move around as much as you can, and maybe there's many patients that can't, but if they'd known more, would they have been able to do more? And there's an element of disbelief that I've seen as well through interviewing those patients, you know, an element of it won't happen to me. So it kind of takes us back to the first theme, but let's look at what Dave tells us.
When I first came out of hospital, you was told about pressure sores and to be careful of them, but you didn't really, I would say, take much notice, but it was sort of, it won't happen to me. But of course, when it does happen to you, it left me, as I say, in bed for approximately 20 hours per day, which meant that, because I was working at the time, so my work commitments had to cease. Family activities were reduced, because obviously you couldn't go out and about because you was predominantly on bed rest, really.
So a huge impact, and I think what's really interesting, which is what I was going to say before, both Ron and Dave are paraplegic, and they don't talk about that and the impact that that has on their life, because they don't see that as having an impact on their quality of life. And as Gwen said, they had a good life socially. They carried on. Having to book the train because of him being paraplegic was a bit troublesome, but not a problem. It was the pressure ulcer for all of those patients that impacted on their quality of life. So in summary, we can see that pressure ulcers have a profound impact on health-related quality of life. And we also know that quality of life is measurable. You know, we've said for a long time it's not really measurable, but actually, you know, from Emily's work, from the studies that I've picked the themes out of, and from talking to those patients, quality of life is measurable. And it looks at, and it's really important to take on board, the physical functioning, the psychological well-being, and the social functioning, and the impact, the true impact that that has on those patients who are living to tell their story. The other themes that were picked out was, Emily alluded to some of this as well, but the inconsistencies in pressure ulcer management between hospital and community, and that might be about communication, but actually some of that caused the patient's fear and distress, the different types of treatment. You know, Ron in another part of that video says, you know, I've had everything, you know, you name it, and I've had it on this pressure ulcer, and the frustration that that brings of, you know, things aren't always working that well, and the pressure ulcer pain not necessarily being assessed, and we see this today, and patients refusing equipment because it's not comfortable, or because the cushions feel unstable, or because it made the chair too high. So lots of issues that then impact on why that pressure ulcer perhaps isn't healing. And patients were able to acknowledge, and this was a common theme, that if they'd had more information about pressure ulcers, they would have been able potentially to take better care of themselves. So it's about that perception, that understanding. And of most of the patients interviewed, they did not know what a pressure ulcer was. And one patient was actually confused with, well, I've heard of a gastric ulcer, but how can I, what's the difference between a gastric ulcer and a pressure ulcer? And that it's the word ulcer that then made me think about, you know, are we using the right terminology? And a common theme, clearly no surprise there, that most patients did believe that pressure ulcer prevention is better than cure. So thank you for listening.
Thank you so much for sharing those patient stories that you were able to interview. I think they really brought to life, listening to the voice of the patient, the evidence that's also there surrounding the experience of patients who live with pressure ulcers. It was very emotional, and we've had lots of emojis showing us that everybody listening was very engaged with the content. So we now have some time to answer some questions that have been submitted. So Alison, if I ask you to remain with me, and I'll ask Alison Schofield back, thank you, and Helen to join us for questions. Both those that have been pre-submitted when people registered for the webinar, and also those that have been submitted while listening to you. Before we proceed, we usually have about 3 short questions before the end of the webinar. If we can ask everybody to answer those, and they'll just help us with future webinars to provide content that we hope that you'll be interested in listening to. So for the first question, I'm going to pick one. It came during your session, Alison Parnham, when you were talking about the first theme, the etiology of pressure ulcers. And the question came from one of our listeners saying, do any of these patients receive support or education from those that are caring for them at any point? So just a little discussion on the support and education that you feel are given to patients who are experiencing pressure ulcers.
Yes, absolutely. And I think that it's a good question, and it does really reflect on what do we give, what information do we give the patients, and is there we do give information leaflets to patients and carers, and we record that that's what we've done, and the nurses will also record when they've had that discussion with the patient and family about the importance of preventing pressure ulcers. But I think the question is, how do we know how much the patient takes that on board, and how much the family really understand. And when we listen to what David said at the end, he was told about pressure ulcers, he was given that information, but there was this element of, I didn't really take it on board, I didn't really think it would happen to me. So there is an element of how do we get patients to engage in that, and maybe there is more. You know, we've got a video that we show patients, we've got a leaflet that we give them, we've got an information plan that we give to carers. So there are those resources that we put into place, but you know, how successful it is, we maybe know less of.
That's wonderful, thank you.
Thank you. And as a follow-on question, really, as a district nurse, I've noticed how difficult it is to get carers involved in pressure ulcer prevention. Are there any ways we can encourage carers to be more involved in reducing community-acquired pressure ulcers? I guess, again, to you, Alison, Parnham, is there anything specific that, you know, we can do to help encourage carers?
Yeah, I think there's lots we can do, and I think there are opportunities. There's certainly opportunities that we've developed within CityCare. We've had conferences specifically targeting carers that we actually put through the media, and it was advertised on local radio, and we did get a really good turnout, but it didn't target everybody. But there were a couple of hundred people there at the conference. That meant there is a growing interest in those carers wanting to. We've got a patient voice group where carers come along that are maybe no longer patients, or carers of patients join that group and have a voice that way, and we can feed in that information. We can target agencies of those private agencies. We can offer free teaching, you know, and if they know that it's their time, but actually they don't have to pay for the education, then that can help. We can develop leaflets and information to give them. We've done sort of overarching care delivery handbooks for personal carers before, where they're maybe not got the same opportunities to access training. Alison, I don't know if you wanted to add anything to that.
Yeah, absolutely. Like everything that you've said there, and this week being, you know, on Thursday, it's the International Stop the Pressure Day, and I know in tissue viability we take the opportunity for the whole week, and so there's, and I know because I've seen on social media the tissue viability teams up and down the UK are doing so many things. Mm-hmm. So you know, often they'll be out in in supermarkets, in the high streets with stands and stalls. So do look out for what's going on in your area. And I know I'm the same in my trusts I've worked in. I've led 2 pressure ulcer prevention teams, and our primary aim was for education within care homes, but also those the home care groups as well. So for people who were listening, who are tissue viability nurses like us, or in a position where you are delivering education, contact social care, like the council, these, just try and get into anywhere and to give that provision.
Fantastic. Thank you both. I've spotted a question that has come in during the webinar that I think is really interesting. It says, being a staff nurse working with the elderly in acute medicine, it's often the confused patients that suffer from pressure ulcers, as these patients can be difficult to position change. So I guess this is looking maybe at hypermobilization, active, somebody who's very active versus somebody who's not getting any positional change. And second part to that question is, do these pressure sores impact even further the adverse effects of COVID during the pandemic? So has that level of confusion further exacerbated? So just to both of you, really.
I remember a patient in a care home once that we were asked to go in to support, who had hypermobility and walked up and down all night, and this patient had dementia, and they developed pressure ulcers, to their feet, underside of the feet, heels, and we managed to get them like some certain support shoes where you can offload and things like that. But it can be difficult, and from in a sleep situation where it's hard to reposition people, speak to OTs, therapists, that collaborative working, because there are sleep systems designed to help to keep people in certain positions. So I don't know if Alison, if you've got anything.
Yeah, no, I was thinking of the dementia outreach team that we work closely with to look at those sleep systems which are for patients with severe dementia. Another sort of thread is the risk of contractures with those patients with severe dementia. So they're for prolonged bed rest rather than hypermobility, where there are different risks of contracted hands, and different pressure points on the body. The heel pressing onto the buttock, for example, because of contractures that you might not see without that level of dementia. So it's a very complex group of patients that. And really what you're going to be doing and how you're going to be relieving that pressure or reducing friction from excess movement perhaps is very individual. But there are anti-friction booties, anti-friction sheets that can help. But knowing the resources out there is critical, I think, this is the problem. How can we start to resolve this?
Yeah, and the person who asked that question said there was a staff nurse on an acute ward, and to do utilise your specialist services that are there. If they don't know, then they don't know to come and advise you. Yes, certainly with COVID, if for patients who have COVID, you get reduced perfusion and etc. And so they definitely, people had an increased risk for sure.
Thank you. So myself and Debbie, we're working between the live questions and also some pre-proposed questions as well. So we will try and cover as many as possible. So here, which is very relevant to this climate, could we have tips for management of pressure ulcers in paediatrics, please?
I don't think either of us are paediatrics.
I know.
We both went silent then.
Oh, we did.
We're not trained paediatric nurses, Alison or myself, and when we're not. But often within tissue viability, you cover the broad range. You're not just in adult nursing, because there are about 5 paediatric TVNs in the country, I believe. One of my friends, Rachel, who works at Great Ormond Street, is one of them, and they are amazing. I guess you apply the same principles in a way. And, for education with children and things, you can use such good animation. And I remember a TVN in our trust for the paediatric ward in the acute developed this, we had the PUG, the pressure ulcer guide, and she created a storybook on, the little dog, and it was digging for the bone, and it was to explain it. So I guess you've got to be very creative, I guess, and support the families, obviously.
Yeah, I read an article by a registered nurse who published in the Nursing Times, and it was singing to the children, but it was the pressure points. So it was the head, shoulders, knees and toes, but it was all the pressure points, and that worked along with Eskin. And she actually showed that by introducing that concept, she reduced the pressure ulcers by something like 80% on the ward. There wasn't a high incidence anyway, but they were able to reduce that. And as Alison said, it's the principles are the same. It's just that the resources might be different. Smaller mattresses, for example. But yeah.
Thank you. I've got a question asking for patients who have category 3 or 4 pressure ulcers on their ischal tuberosities. What are your recommendations on seating out in the community setting, please?
We would, as a tissue viability service, recommend not sitting on category 3 or 4 pressure ulcers. If there is another reason, like the only time the patient can eat and drink when they're sitting out, is there any way that they can eat and drink sitting in bed? But if other interventions have been tried and the patient has to sit out, then we would say, we have to take that important aspect of prevention into account and management, but only for meals. So to maximise that time, to an hour maximum, providing they've got a high level of pressure relief. And there are, of course, pressure relieving cushions available that are alternating. There are air flotation type cushions. So you would up the level of cushion to be able to enable that patient to sit out, because sitting out and everything we heard about this prolonged bed rest and the impact that has, sitting out of bed is really important. So I think it's a really good question. But if somebody's sitting for prolonged periods of time on a category 3 without that higher level of pressure relief, the pressure ulcer will get worse.
And
So
it's
a fine balance.
Yeah, and it's those, like, back to those conversations and informing the patients and their families and carers, because it is so hard, isn't it, to say to somebody right now, you know, you're going to go on to bed rest, because we don't want to be dictating to people, you know, what they're doing. And it's about developing that care plan with them. And there may be times when, you know, a seating plan is part of that. But I mean, you know, just listening to your videos, Alison, of your patient stories, and I know I did one 2 years ago, Diane's story, and I actually retweeted it yesterday, and Medstrom kindly sponsored us to create that video at the time. And, you know, it was the same situation, and this lady had to, you know, she was in bed for, I think it was about 2 years. I mean, thankfully a pressure ulcer is now healed, but it was a category 4, and that was the hardest thing for her, because she was very social and very active. So it's, you know, it's the approach and things, and making sure, you know, profiling beds can be turned into a chair.
Yes.
You know, yeah. So you have to look at, you know, all the different aspects of care.
Okay, thank you. So another question, when does a pressure area become unavoidable?
I'll start with that then, Alison. That it's a difficult question. Firstly, we don't use the NHS improvements recommended in 2018 that we don't use the word avoidable and unavoidable, because it suggests someone's being blamed, and that's not what the reporting of pressure ulcers was ever meant to be about. It felt that that's what it was when we started to use this is avoidable, this is unavoidable, and so it's about lessons being learned, and that's very much the approach now. What can we learn from this? We're not pointing the finger, making somebody held to account for this, but as an overall incident, we want to know what lessons can we learn to make sure that it doesn't happen again. In terms of there are no lessons, we can learn no lessons, that's pretty doubtful. Often somewhere along the way, we can reflect on the whole episode of care for that patient and say, well, actually, that's the bit that we could have done differently. It may not have been the root cause of the pressure ulcer, of course, so there are lessons to be learned. If we don't find a root cause, because every aspect of preventative intervention was visible, recorded, evident, and the patient developed a pressure ulcer despite all of those interventions, then you can say, you know, we don't have any lessons to learn here. The nurses and their team and the medical staff and the professions allied to medicine did everything they possibly could. So that's the kind of cutoff, but it's just remembering that. Would you agree, Alison?
Yeah, I mean, and that's why we have the root cause analysis process, you know, to look at the root cause of the pressure ulcer, you know, where's it started from. You will often find something when you delve deep, and important to that is the documentation, because if documentation is really good, valid, intact, then when we are looking then backwards to when and before the pressure ulcer actually occurred, what happened leading up to that, it will tell us a great deal, and to speak to the patients and the carers, the family, everybody who was involved in leading up to the pressure ulcer development.
Thank you both. Talking about lessons learned, a question that's come in during the webinar has been, now that we have shared experiences during the pandemic with COVID, of the lack of resources, GPs appointments, etc., do we feel that there is a robust contingency plan in place if there is an increase over the winter period?
Well, I think obviously just having the awareness of the situation of what's happening. I mean, it was, it's unprecedented, really, was the COVID pandemic, wasn't it? And, and it's still rumbling along, and we know winter pressures happen. So I think just having that awareness of it now, and making sure we've got our educational programs in place, that we are, we're doing our risk assessments, we're not kind of, and that preventative care, that it's not, just been on the back burner. Pressure ulcers have always been a very, given high status within our trust because we measure them. It's a safety incident. So every area should know what their incidence level is, you know, and often there's steering groups and etc. and things that are happening to try and look at that. So on a national level, you've got the National Wound Care Strategy Programme. They have the pressure ulcer group within that, but also look on a local level what's happening within your area, because I can't imagine there isn't things being put into place.
Okay, thank you. And now we've had quite a few questions actually around non-compliance. So can you discuss non-compliance, especially where an investigation may take place, where this has been a factor, and really how to manage non-compliant patients?
Yeah, I think understanding or seeking to understand why the patients are not engaging with that with the plan of care. How do we get this patient, because it's not about telling the patient what to do, it's not about them complying, it's about them engaging with you as a healthcare professional. And so the first question would always be why. Okay, I completely respect the fact that you don't want to use this mattress, but can you tell me why? Because there are other mattresses and that we might be able to look at something else. And if there's nothing in British Red Cross, then we can look at maybe something bespoke for you. So it's not handing them everything on a plate, which is not within the finite resources that we have, but it's about recognizing not everything suits all patients. And also the important thing of capacity. Is this patient making an unwise decision and they have capacity, or actually are they not able to make their own decision? And actually that then becomes more about safeguarding in terms of why are they, understanding if they have capacity and why they're making that decision. And if they're not making the decision because they can't and a relative is making the decision for them, then we can go down the safeguarding route. But if we feel that the patient is not engaging, then certainly within my organisation we can take that for support to our safeguarding team and to the review panel for discussion. But it may be that we go and see the patient and that we formalise that patient's decision and look at the engagement checklist, which is in quite a lot of detail of why does this patient not want to engage with that particular service. It's a tricky one, I know, but I think the key is about finding out why and what else can be tried, and not just saying, oh well, they don't want it, so we'll discharge them. It's certainly not about doing that.
And we are going, when patients are in community, it's very different to patients when they're in that acute setting. So we are going into their homes, and patients have told me sometimes in the past, they understand the information, they can process it and everything else, but they don't want their houses turned into a hospital ward sometimes, is what they've said. So, sometimes it's just around certain things like that. So we have to respect, sometimes people make poor choices, but just make sure that everybody is very well informed and have comfort, dignity and safety all together.
Thank you both. I think this is a very similar question, possibly. What are your thoughts about managing the needs of the service user with their quality of life, often when out in a chair or mobility aids, versus recommendations of offloading and repositioning within bed for extended periods? So I suppose that's talking on some of the psychological elements that you were talking about in your presentation as well.
And it's also about not wanting to deprive patients of their liberty, so DOLS comes into that to a certain extent as well. And so it's finding that balance, and the patients that you listen to spending those hours in bed had a huge impact. So it's about getting that balance. It's about, if we upgrade your cushion, then let's pressure map. Let's see if you are, what levels of pressure are in your chair compared to the levels of pressure in the bed. We did that with a young lady in her late 30s, early 40s, who had MS, and she wanted to go out of an evening to the pub with her husband. She wanted to carry on living her life, but she had a category 4 sacral pressure ulcer. And so we pressure mapped the bed and pressure mapped her chair. She had a very high, she had a bespoke wheelchair with a high level of built-in support into the wheelchair. And by pressure mapping, having encouraged her to spend a longer time in bed, the pressure mapping showed that actually she was getting really high levels of pressure relief in the chair. So we were able to say, you know, you still need to change position between bed and chair, but actually you're going to be okay for a couple of hours in that chair. Because we were able to measure it. So I think that's quite important. And I think it's a really good question. It is a balance between we're doing this for the patient's quality of life, and equally at end of life, you know, is the patient in a lot of pain when they're being repositioned towards the end of life? And do we then not regularly turn them as regularly because of, and that's a patient, family, clinician decision that makes it very individual for those individual needs.
Okay, thank you. We've got another question here that's from the live webinar asking, and it's really touching around sort of repositioning patients, but also the need for sleep and, you know, getting the balance right. So the question is, we are instructed to turn patients 2 hourly, even at night. Is this really more important than the patient getting a good night's sleep?
There was a lot of talk about this in the past couple of years. There was an article that was published around this. It created a lot of chatter around it. And again, it's back to that, you know, it's individualized care planning, and, you know, that patient quality of life. You know, we do follow our guidance, such as NICE guidance, European Pressure Ulcer Advisory Panel, and it tells us in there about reposition if somebody is at risk or has a pressure ulcer. But, you know, if sleep is an important element of somebody's well-being, as is, you know, nutrition. So we have to look at all that on that individualized basis. What is the greater risk? You know, and do we need to be? And we have systems, we have great equipment now, you know, really offloading floated mattresses that reposition without us having to make those physical turns. So look at resources that are available. Alison, you'll have an opinion.
Yeah, no, I would. Yeah, I would completely agree. You know, patients aren't turned 2 hourly in the community, so the 2 hourly turning is probably more of an acute policy. And I would agree that does disrupt patient sleep. If we expected carers to do that in the community, the carers who may be quite elderly themselves would be confused with sleep deprivation and probably delirious. So we have to look at that impact as well. And the equipment compensates for that. 2 hourly repositioning, we believe, and I'm not old enough, well, I feel as if sometimes I'm old enough to have worked with Florence, but it certainly came from Florence Nightingale. We believe that, you know, she was repositioning to, you know, the soldiers every 2 hours, because that was the time span to get down one side of the Nightingale ward and up the other. And those patients, those soldiers, were lying on wooden planks. It's very different to what our patients, and yes, there are different risks, but it's very different to the equipment and the high level of pressure relieving equipment that our patients have today.
That's wonderful. Thank you both. So touching on equipment, I'm just picking up another question that's recently been submitted. It says that in-bed automated turning systems tend to achieve 30 degrees of tilt to relieve pressure on the sacrum. Is this a clinically effective method for preventing pressure ulcers, or is a full turn to the patient's side with carer assistance preferable?
30-degree tilt is what we want to aim for anyway, and you can even sometimes go slightly less than that, but you don't want to be turning people over right onto their side, onto a full turn, because we don't want them on their hips, because the hips are going to break down. So with a clever use of pillows, and I know pillows sometimes in some settings, there just isn't any pillows, but you know, you or the sleep systems, you can achieve that. So it's, you know, that is just that tilt, that offload off the sacrum when somebody is in bed.
Yeah, I would agree. And there are mattresses now that can produce, you know, a 30-degree tilt every 10 minutes, or you can set it to every hour, or, you know, the technology for mattresses currently is really good.
Yeah,
you know.
And for people in their own homes, like we were saying, you know, in community, you know, I've had patients where they live on their own and they have pressure ulcers, and we've put tilting devices in place, and you know, and it's been very, very successful for them.
Yeah, and cheaper than employing a carer two
Oh,
carers overnight to reposition. So actually, if we apply to continuing care funding for those beds, they're more than happy because it's cost saving.
It's a good point there, because sometimes it's like there's always the bottom line on equipment purchasing, and sometimes like, oh well, it costs this much money. Actually, if you calculate that, and I did that once with it, and looking at night carers, the cost saving is significant amount. So
those are great responses. In fact, it's actually covered off a couple more questions, and one of the questions was around how do you support low-end patients who don't have a carer. So obviously using equipment to assist with that is key. And then another question, just if you could expand on COVID toe.
Oh, right. Okay.
What is it? Is the specific question? Obviously, I think it was Alison Schofield. You put some pictures up on your presentation.
I did. It was these like manifestations of discoloured areas, almost a bit like deep tissue injury. And I think we presume it's if people have COVID, obviously it's like respiratory illness, they have reduced oxygen, so reduced perfusion to the capillaries, and especially in the smaller vessels, kind of around the feet and toes. So it was just something that kind of was being seen, and people experiencing types of pain like neuropathic pain and things. So yeah, it's we're still learning about all these things.
Thank you.
Thank you both. We have had some discussion about turning strategies or sleep systems, but we've got a question asking if you have any suggestions, because somebody says they encounter and encourage turning and movement, but they've got patients with contractures.
Yeah, I think we Alison and I both mentioned sleep systems which are suitable particularly for patients with contractures, because the cushions come in all sorts of shapes and sizes, and they're like a pressure reducing beam structure, so the beads, sorry, not beans or similar, but some of those beads can be removed to meet the shape of the contracture, to stop knee to knee contact, to stop heel to buttock contact. So it's very much a bespoke, and what the OTs, the dementia outreach team, will do is actually work in pairs and work with that individual, get them into a position that reduces pressure points, that's very comfortable, and actually they then photograph and use that as a teaching educational tool for if it's a care home, for example, that would go up on the patient's wall, so that when the carers are attending to hygiene needs, they've got that as a guide to, this is the position that this patient needs to go back into, this is the position that they need to change to. So it's very much working with those contractures on an individual basis. But the other one are the fat mimicking pads for contractures, where you can play, if it's a hand and the nails are digging in, then you can place the fat mimicking pad into the hand or behind the knee, or where you've got in between the knees, where you've got that bone-to-bone contact. So there are lots of things that can be done specifically for that patient group.
Thank you.
Thank you. I doubt, ladies, we're running out of time, but we've covered a lot of questions there. Any questions that we haven't covered will be responded to after the event. Lots of lovely comments as well as the questions to say what fantastic presentation. So thank you very much to all of our speakers, and Emily, obviously, who can't be with us live. So from myself, Debbie, and the whole team at Medstrom, we thank you very much for joining us, and we will soon be issuing a webinar program for 2022. So thank you very much, and goodbye.